So first of all, I just want to get a sense of who's in the audience. So who are physicians here? Almost everybody. Who works for VCH in any of the downtown east side clinics or any clinics doing opioid agonist therapy? Okay. And what about other private practices? Are you doing opioid agonist therapy in your private practices? Nope. Okay. So maybe potential for some expansion. So I'm going to be telling you how we're getting teams at the front lines of the opioid crisis to drive system change and improve care for our patients. So that's me. David introduced me. A few disclosures. I've got a couple travel grants over the past 2 years. Mitigating bias, I won't be talking about HIV or hepatitis C therapies. And final disclosure, the data and graphs tend to excite me a tad more than my colleagues, or so I've been told, or so I've overheard in the clinic. Okay, so I want to tell you what you already know. There's an opioid crisis, so if you're searching opioid on the CBC website, you're getting thousands of articles back. We all know this. We see it every week. Tell you a bit about my view from the front lines, talk a bit about what's driving the crisis, a bit of a discussion about system gaps, which can be a long discussion, and then how are we going to try and fix these? So what works according to research, and how do we actually get that knowledge into practice? What progress are we making so far? And what are the broader implications of this work? So hopefully you can start thinking about how this could be applied elsewhere by the end of the talk. So by the end of the talk, hopefully you'll be able to describe a bit about what the Boost Collaborative is in terms of our aims, how we're measuring things, the change ideas we're testing, the structure, the teams who are involved, and what the teams are actually doing. So they're using quality improvement methods and more specifically the model for improvement to hopefully drive change. I want you to come away with an appreciation of the importance of standardizing clinical data entry for gathering our measures and doing our quality improvement work, and some questions to think about by the end. How does this work relate to your daily practice? So, if you're on the START team, like one of our audience members, they're a team who's involved in the Boost Collaborative, but you can really apply these methods in your private practice or even in other facets of your life. And so what other clinical topics might be ready for this application, be it just quality improvement and PDSA cycles or for a total collaborative approach? Okay. So most of you have probably seen this slide or something like it. Okay, we know that there's been a huge increase in the number of illicit overdose deaths, mostly due to opiates, mostly due to fentanyl over the past 2 years, and it looks like 2017 is going to be far worse than 2016. So I'll tell you a bit about what I've seen on the front lines. So I've changed the names of these patients and just tell you a bit about some of the not great outcomes I've had with some of my patients. So this Jake, male who's in his 50s, had remote history of opioid use disorder, had told me he'd been clean for years, chronic low back pain, saying Advil has some effect. But most of our visits focusing on other things. He's working part-time and enjoying being productive, plans to visit his family finally in another province. I get a call from the coroner. He's been found dead, surrounded by fake oxys, and they think they're likely fentanyl. Another guy, Paul, he's a pleasant guy in his 40s. I'm seeing him at the HIV clinic preparing to treat his hepatitis C. He's back at work, attending all his appointments, and motivated to get his hep C cured. Only 1.5 weeks into this curative but hugely expensive treatment, his primary doc comes to me and says he's died of an overdose. This Dan is quite a marginalized guy I was seeing at the IDC when he actually came in. Male in his 20s, HIV positive, MSM, history of alcohol and stimulants, but had only in the past few months started opiates. We had the Stop HIV outreach team working with him, trying to engage him. We tried Suboxone once. He failed. He was motivated to try again and maybe try detox. But before we got to that step, only a few days after he expressed that to the Stop team, he was found dead of an overdose. Sabrina, I saw at Ravensong. She's a female in her 20s. She having problems with opiates over the past 2 years or so. We got her on Suboxone a few times. She was working so much that she would end up missing clinic appointments and then falling off the Suboxone because of that, reverting to opiate use. We had her back on 8 milligrams, which is a fairly low dose for Suboxone. Not enough, apparently. She went and picked up a supply with her friend. They went home to their separate homes. He didn't wake up. She barely woke up. So she lost one of her best friends. And that was one of the first deaths linked to the stronger carfentanil. And then finally, this guy, Alex, he's a male around my age. I'll let you guess what that is. He was seen on the weekend at Ravensong, so it was a fairly slow clinic. I was able to spend a lot of time with him, really trying to understand what his needs were, and I thought I was, able to get him to agree that getting on methadone would be a good thing. He could go right to the pharmacy and get it that day. But I checked Pharmanet the next day, and the prescription was never filled. So looking back at these, my initial reactions, and I'm sure a lot of the clinicians in here, we look back at this and we're like, what could I have done for better patient outcomes? There's probably a lot of answers for that. How could I have prevented this? So that's the initial reaction. But, if you take a step back, you have to realize you're only one part of the complex healthcare system and the society these patients were trying to maneuver in. So I think it's better to say, how can we change the system to get better outcomes for patients like these? So what's driving the crisis? I'm sure it's multifactorial, probably driven by a poison drug supply, so fentanyl and derivatives coming from China is probably driving this. And then the ongoing battle between, is this a public health problem or a criminal justice problem? I think we're moving in the right direction with that, but lots of work to be done. More so in this talk today, I want to talk about the internal factors or parts of our system of care that we can change and we can start trying to change right now. So I saw an excellent talk going over some of the key drivers of the crisis and what can be done about it. This was by Mark Tyndall, the medical director of the BC CDC, and he did this at this Hep C in substance users conference a couple months ago. You can look up the talk. It's available in video on the conference website. So he talked about the key ideas that came out of the BC Overdose Action Exchange, and you can see them here. So you can see that this is the total list of what they think can be done to fix the crisis. My question is, what can our frontline teams start doing right now? And it looks like we can probably touch on at least most of these. So, system gaps, I'd rather call them system opportunities, okay? Meaning that we can hopefully change our system to provide better care. And if you ask the patient, they'll tell you a bunch of gaps in our system, like limited hours, not being able to get phone refills, these things. The family will tell you even more, and the frontline staff. So if you ask clinicians here involved in the field or nurses or front desk staff, they'll come up with more things that we could probably be doing differently and to have better outcomes. We also have the science to assist us, so we know what works in terms of getting better outcomes. And these are brought together in the treatment guidelines that we have. So we have new guidelines for the management of opioid use disorder, and that's from the BC CSU. Okay, and specifically with methadone and Suboxone or buprenorphine, we know that if people are on these, they're getting better outcomes in terms of treatment retention, withdrawal suppression, decreased illicit opioid use, reduced risk of incident infection with Hep C or HIV. If they do have HIV, they're more likely to adhere to their antiretrovirals, decreased criminal activity, and finally, probably the most important one is decreased mortality, both overall and substance-related. Okay, we also know that retaining people on therapy is the most important thing. So if we get people started on it, but they don't last on therapy for long, we're not really getting the benefit of the reduced mortality, all-cause and substance-related. So retention is an important part of this. So we can look at some provincial data to further flesh out the system gaps or opportunities here. This was a report of data going up to 2016. This is a March 2017 report. So on the left here, you can see that this is the percentage of clients started on methadone who were retained on therapy for 6 months. So most of these patients, they should be retained on therapy for at least 6 months due to the chronic course of this illness. You can start tapering people off of this therapy, but usually you want everything else to be stable and them to have a good months, many months to at least a few years of therapy. Now you can see that, for example, BCH, it looks like by 2014, 2015, there were only about 39% retained on therapy by 6 months. Of course, the numbers are even worse if you're looking at retained on therapy after 1 year. And it seems that the numbers were going in the wrong direction, at least between 2010 and 2015. So we also know that you need a certain amount of methadone or Suboxone to get your best outcomes. So people on at least 60 milligrams of methadone or 16 milligrams of the buprenorphine component of Suboxone have better outcomes than those on lower doses. So lower mortality, morbidity, less likely to be using illicit opioids. Now, that's not 100%. I certainly have examples of patients who have been stable and not using opiates on lower doses, but this is looking at the research and a cohort of patients. So what can we do about this? How can we fix this? So the trendy thing now to do is a collaborative. So I want to tell you what a collaborative is. First of all, it's been done before. It's been done for HIV, so you can draw similarities between what was happening in HIV and what's happening now in the opioid crisis. In HIV, we had effective treatments, but in BC, people were still not getting their viral load suppressed. So a collaborative was used, and you can see the graphs on the right. Through the course of the collaborative of about 2 years, they were able to bring their proportion with undetectable viral load for 6 months from 57% to 78% using this approach. This NIATEX collaborative, that's in the States. It's a very large collaborative, and that was in people with substance use disorder. By the end of that, they had 200 different clinics, and they were showing improvements in their patient outcomes. And then there are many more examples in the literature looking at different clinical issues. This is the structure of what a collaborative is. So we select our topic, we recruit some expert faculty, develop a framework of changes and how we're going to measure our outcomes. We then enrolled our participants or our teams, got them to do some pre-work, and then we launched our collaborative back in September. After the launch, the teams go away and they do the actual quality improvement work, and then we follow up again in December and have 2 more learning sessions after that. So I'll tell you more about what the teams are actually doing during this. This is specifically for our Boost Collaborative. We had the working group meeting in July, so that's where we develop a lot of our change package and our content I'll tell you more about. We launched in September, and we're now in this October to November 1st action period before we have another learning session on December 7th. This is our core team, so I get half a day a week to work on this. Danielle on the left she was clinical practice lead at BCH. Now she's back to school, but also doing consulting work on this. And then Laura on the right is our quality improvement coordinator working at the BC CFE. She's doing the lion's share of the day-to-day work here, and then we have Angie helping with our administrative work. So here are our teams who are involved. So I think we have somebody from the M here, the START team. So you can see we have a good mix of primary care, substance use teams, a couple mental health teams. Overdose outreach should be on here. We have Vancouver Native Health Society. We have these new stabilization clinics, so they're downtown Eastside connections, and at St. Paul's, the Rapid Access and Assessment Center. So as I said, we launched in September. We had to get stakeholder buy-in and an engaged leadership. So you can see we have the head of the CFE and Mary Akiners and the head of VCH at our launch, along with Rolando, who was instrumental in that HIV collaborative that was done within the last few years. And then we had some good press with an article in the Globe and Mail when this was launched. So what's the goal of the collaborative? We want data-driven improvement at the front lines. So specifically, we want to improve the care of our clients living with opioid use disorder. This has come to be important now because the increased number of overdoses, but we probably should have been doing this even before the spike in overdoses, because there were still a lot of care gaps, and I think we're getting better. But this really puts a focus on improving our care. Other benefits of running a collaborative, besides doing this frontline QI work, we are able to collaborate between teams, pool resources, expertise, know what other teams are doing, what other teams are offering. And it's a chance for advocating for broader system changes. So if we have a big group of frontline teams come together and we see system change that's needed, we can advocate for that. Okay, so what are the teams actually doing? They're doing quality improvement and using the model for improvement. Okay, so most of you or some of you have probably heard of Plan, Do, Study, Act cycles, or PDSA cycles. So that's what teams are actually doing, and then they're reporting that to us with monthly quantitative and narrative reports. The Institute for Healthcare Improvement is an organization in the States that really champions this approach to healthcare improvement. The goal here is reducing lag from guideline to implementation. So we know a lot of guidelines will even never reach implementation in day-to-day practice. And you know, as a frontline clinician, right now I feel, and I think this has been studied, if you're trying to follow the guidelines for every clinical condition for your complex patients and you're trying to do this alone, you don't have enough time in the day to do that, let alone have a discussion and develop a rapport with the client. So I think we need to change to a more team-based care approach and change the system so we can really keep up with the best evidence. So this is a model for improvement. You may have seen this before, so it's very simple, okay? On the left, we're answering 3 questions. What are we trying to accomplish? Those are our aims. How will we know a change is an improvement? Those are our measurements. And then what changes are we testing that may result in improvement? So that's our 3 questions in the model for improvements, our aims, measurements, and change ideas. That formulates our plan. We then, on a small scale, usually first, we carry out that plan, we take our measures, and then we get to the study phase where we're looking at our measurements. And then we decide, did that change work? Do we know if that change worked? Do we need to modify it? Do we need to discard it? Or can we implement it? Now, we have a couple documents that came out of our working group and our pre-work to guide teams. So a change package, which is a pretty exhaustive list of changes teams can try to improve their outcomes, and then how we're going to measure our outcomes. So quality improvement is not about evaluation. It's not about judging individual providers. It's not performance assessment. It's not quality control. So we're trying to improve things, not keep status quo. And it's not research. we're being guided by research, but our goal is improvement in our service delivery. It's not answering new questions. So it's a bottom-up approach. It really values the frontline team as the drivers for change. So often the frontline team has the best view for where the service gaps are. It's a systems approach, and as I said, you test small changes first and then expand scope and scale. An example, back to that optimal dosing. So say our clinic only has 50% of clients on optimal dosing of opioid agonist therapy, and the frontline team thinks we can do better. So maybe we want our aim to go from 50% to 90% of our clients on opioid agonist therapy over the next 6 months. So this gives us our aim statement for one of our PDSA cycles. So you want it to be specific in terms of numerical targets and by when, and have a specific goal in mind. So the team decides, what change can they test to try to improve this. They're going to get the nurse to run a list of clients not on optimal doses, and then review those with the clinician to see if there's anything we can do to get them up to an optimal dose. So how will we know our change is an improvement? So the outcome measure, this one's simple. This is the proportion on optimal dosing. We're trying to get that from 50 to 90%. We also want some process measures. So we want the team to be recording how often they're actually doing the change. So in our example, it'd be percentage of weeks that the nurse actually runs the list. So maybe she gets pulled away to do other work 3 out of the 4 weeks, and the change never gets tested. We need to know that. And then we need balancing measures. So our changes causing problems to other parts of the system. A common one here would just be the time taken to do the work if it's pulling away from other work. Over time, we want to see that our outcome measures are gradually increasing as we're recording. You may be recording more frequently than once a month. So I'll show you an example a bit later where it's once a day instead. But this is a general idea of a run chart. You'll have your goal line, the outcome measures, and you can also record some of your process measures. And then this is really demonstrating that you're doing the work, and it's hopefully having some effect on your outcomes. So those PDSA cycles, that's what our individual teams are doing. And the measures like the one I just described would be PDSA level measures. So what they're doing with each PDSA cycle. Hopefully those are getting our teams towards their site-specific aims. Okay, so our Boost Collaborative, we have an overall aim statement I'll show you. But then the teams have site-specific aims that are more tailored to what their individual clinics do. Hopefully they align with our collaborative aims, and they get to then report on collaborative level measures that I'll tell you about, and hopefully with all this, we're improving our collaborative outcomes. The dropout rate, in terms of teams dropping out, patients dropping out, dropping out among our teams, is that what yeah. Well, I think you can look at that provincial data, right? In terms of retention on methadone by 6 months, you're looking at around half of people being retained. We don't know the retention, so we're just starting and we don't even have complete baseline data for our teams, so I'm not sure I can answer that for our teams specifically, but we can get an estimate from that provincial data. So the PDSA cycles that the teams are doing and hopefully drive them towards their team-specific aims, and they hopefully align with our overall aim statement. So our working group crafted this. So we want to have, by July 2018, we aim to provide equitable access to integrated evidence-based care to help our patients with opioid use disorder achieve 95% initiated on therapy. So that means have 19 out of 20 at least tried opioid agonist therapy. 95% retained for at least 3 months. So we know that we need people to be retained on therapy to actually realize the benefit. We can stratify this differently. So, if most are being retained by 3 months, we can then look at 6 months and longer. And we also wanted to step back and look at our overall quality of life, because our first two goals here are focusing specifically on medications. One message we were getting from our interdisciplinary teams and from our peers involved in the process is we really need to look at the whole patient and make sure we're assessing things like chronic pain and mental health. And so that all drives into the quality of life score. So if you've never seen a driver diagram before, this is our Boost driver diagram. It basically is a schematic showing the key themes or topic areas that will help us reach our aims. So you got our aim statement on the left there, and then we think our primary drivers will be dealing with education, dealing with the actual treatment, our leadership, the other medical care we're giving them, and then a huge one, I think probably the most important here, is engagement. Okay, we need to be better at keeping our clients coming back to the clinic, paying attention to their social determinants of health, setting up a patient medical home so it's easier for them to access services than traveling all across the city and ending up not making appointments. We need to practice within a trauma-informed lens, so probably a majority of these clients have some past traumas, and we need our cultural competency, really. So a lot of the changes in our change package, or all of them really, will fall into one or more of these secondary drivers. Okay, so your testing changes that we think will drive our outcomes. How are we going to measure our outcomes? Okay, so we have a few collaborative level measures. We're going to measure engagement. We're going to measure what percentage of our clients with OUD have access OAT, so that's access. We're going to follow how many of our clients, or what proportion of our clients, are actively on OAT out of all of those identified with opioid use disorder. We're going to check the percentage on optimal dosing, where we know what an optimal dose is. We're going to follow retention on therapy, and then we can assess quality of life scores periodically. Okay, but first things first, this may seem straightforward to some people in private practice. So when somebody asks you, can you give me a list of your panel of patients, that sounds like an easy question, and it may be for some of you on EMR. It becomes a bit more complicated, especially in the VCH EMR, because things get outdated or not added. Okay, so we need to know our panel of patients in order to measure their progress and their outcomes. Okay, if we don't have an accurate list, then we're not measuring the right people. So in our profile EMR, we need that POS, or point of service, set correctly, and we need the most responsible provider set correctly, and we only want to focus on active clients. So if they haven't been here in a few years, but they're still open in the EMR, we need to get that closed so we're not measuring their outcomes, because our changes aren't affecting them at all. We also need accurate problem lists. So in our EMR, you could find anything and everything for a person with opioid use disorder. It may have nothing in the problem list. It may have just methadone. It may have just Suboxone. So we chose a standard diagnostic code, our 304.0 opioid use disorder, and we've been trying to add that for each client with verified opioid use disorder. So I don't know how many of you know Danielle Martin. So she's on the CBC a lot. She became famous by advocating for single-payer health care to a U.S. Senate hearing, I believe. She's a family physician in Toronto, has a great book. It's called Better Now. She has her 6 big ideas for changing the Canadian, or improving health care for all Canadians. And a main theme in this book is talking about data-driven improvement. And so related to that, we really need to recognize the importance of standardizing some of our important data entry items. Okay. One common thing I've heard trying to do this work is this, but I hate EMR forms. Okay, people have had terrible experiences with them in the past, so it becomes difficult doing the standardization. So here's the form we are using in our electronic medical record. And so we consulted with some of our frontline staff, and including me. So I'm working in 2 different clinics. I prescribe OAT at both of those clinics. And so we had this previous form that was many pages and very overwhelming, especially for most clinicians working in primary care. So we pared it down to the bare essentials here and now have a 1-page form and with many benefits. Okay, so on this form you can add your diagnostic code if it's not already in the problem list by just checking on it. You can see the last 2 methadone or Suboxone or Cadian prescriptions, so that could guide what you're going to give today. You can check that PharmaNet's been reviewed. You can put information about missed doses and current substance use, number of ODs, questions about having a naloxone kit, naloxone training, awareness of supervised consumption sites, all stuff like that. And this prescription creator, it allows us to put in the information we need in a standard way, and then you just hit Create RX, and you'll be able to get your prescription in a standardized way. So our goal is for everybody with opioid use disorder that we have at least one of these created, and if their OUD is active, then this should periodically be happening. If they're on OAT, we would like that all the OAT prescriptions are created using the form. It doesn't mean you have to fill out all the parts of the form every time. You may just use the prescription creator, but this just really helps us to standardize how things are entered and track daily doses and keep everybody on the same page. So we've done some PDSA cycles in trying to get people to use the form, and I'm happy to report that it's been doing quite well. So from September 17th, that week, we only had 50 people use the form. Now by the last week of October, or October 29th, we have over 560 forms created in a single week. Okay, so this was taking constant feedback from the frontline users and making modifications and tweaks and making it better and more useful. And we have a lot of more changes that we're going to do to the form to make it even more user-friendly. I also made some screen capture videos of how to use some simple parts of the form, so these are available online. And so we can look at some of the data. So I can compare in the EMR the Suboxone and Cadian prescriptions made using the form versus not using the form. And you see using the form in the blue line, that has gradually increased over the weeks, whereas the number created outside of the form is going down. So we're getting more people to use the form to create their prescriptions in a standard way. One shining example, this is data from one clinic. So you can see at the start of this period, only one person used the form in that week to create their Suboxone or Cadian script. But by the end of this time period, there were only 3 prescriptions created outside of the OUD form. And this is great for this clinic because I think they have 16 different physicians working at very short periods. So it shows that really you can get people to be using it even if they're only in the clinic once every week or 2. They use regular communication with About Boost with the clinic staff. They did some training where it was needed and reminding people at morning rounds and team meetings. So I'm hoping this is an example of what's called highly adoptable quality improvement. So there's a good website reviewing what this means, but ideally we want to be on this workload versus time graph. We want to end up being on the green line here. And I think I've convinced myself that that's happening, at least with the OUD form. I think I'm spending less time on a lot of the routine work we do with our Suboxone, methadone, Cadian visits. So these bumps in the road are, the time it took to prepare the form, the time it takes to learn something new. But I think we're going along this green line, which is the ideal approach. I've had some pushback in terms of how long it takes the form to load. I think there were other EMR performance issues ongoing at the time. I even had one of my skeptical physicians send me a screenshot of a stopwatch time he had used when he opened the form. So he's saying it took 2.21 seconds. He wanted it under 2. I told him to do his daily mindfulness exercises during that time. So I think he's bought in now. Okay, back to this empanelment issue. So we want the same diagnosis in the problem list. We want to know it's at the right point of service. We want the right MRP. Great example of the work being done to do this. So at Pender, they have quite a few OAT clients, but they were able to really do this well. So on our baseline population of focus query, that's searching just using keywords in the problem list. So it probably slightly overestimates the number of people with opioid use disorder because we're just searching for methadone, Suboxone, Cadian, opiate, opioid, OUD. So not all of those problems in the problem list with those keywords will actually be in people with OUD. But they got it to where they have 90% of those folks with the 304.0 in the problem list. So it looks like they were able to go through this baseline list and make sure they had that standard code where they need it. And they have a form created for 57% of that 90%. Okay, so remember the goal is to have at least one form created for each of those. Skipping ahead here, there's still some problems with entering some dates on the form. So the most recent OAT start date and the first OAT start date ever. These are things on the form you only have to enter once, and that allows us to measure our OAT access and retention on therapy. So I think most of our teams are still working on that, and hopefully that will start filling in soon. We're able to look at the number of active prescriptions. So it looks like, excuse me, about 51% of their clients with OUD have an active prescription with them. And about 69% of those clients on methadone and Suboxone are on optimal doses. Okay. Like I said, not many people at the start of this had a standard problem in the problem list, so it's very hard to determine what our size of our population of focus is. So opioid use disorder clients at our clinic, we could estimate using that keyword search, and that's how we got this 3,700 clients, probably an overestimation. Most recent data shows that we're up to 1,953 clients with the 304.0 in the problem list. This is way up from 629 just at the start of October. So there's quite a bit of work being done in terms of standardizing this so we're able to follow these patients. Okay, this gets back to what our teams are actually doing. So I'll give you an example of this, and that's aligning with their site-specific aims, aligning with our collaborative aims, and hopefully driving our collaborative outcomes. So at the IDC and at Ravensong, the two clinics where I work, but this is work going on independently of me. It just so happens that I work there as well. They're trying a reminder list so they can get a list generated from the EMR of methadone scripts coming due, and then they're doing reminder calls to patients and seeing how that's working. So they're doing some PDSA level measures. They're checking out of those clients who have a script coming due, what proportion come in on the appropriate date to get that refilled. And then they're tracking process measures like the number of calls made, the number of calls answered, and a balancing measure of how much time it's taking to do the work. Okay, and then hopefully by doing that, they're affecting some of our overall outcomes, okay? So you can imagine that if people are getting reminder phone calls and missing less doses, they may be more engaged. They may be more likely to have an active prescription. We may be able to get them up to an optimal dose more easily, hopefully retained on therapy better. So if people miss multiple doses, they may fall off of therapy. And then hopefully their quality of life is better because they're on a stable dose and retained on that. So over the course of the collaborative, we want our teams to be moving from, cleaning up the population focus. We're doing the empanelment work, figuring out what PDSA cycles are and what quality improvement is. And we have this assessment scale. So you can see kind of the maximum our teams are at right now is 2.5. So 2.5 here, you see components of the model being tested, but no improvements are noted yet. And data and key measures are being reported. So usually what happens in the collaborative, and we're in the initial phases, is people start here, and then some teams by the end may reach 4.5 or 5. The hope is that everybody can. And this is what we're trying to move teams towards. So reporting on multiple outcome measures, showing that changes have been implemented, improvements are sustained. So really over the course of the collaborative, we want teams to be thinking about what they need to do to get to the next level in this assessment scale. So just a bit about some initial data I'm able to pull out related to the collaborative. We can see that overall numbers of methadone prescriptions have gone up within our system, and kind of tracking with that is the number of clients on methadone with 60 milligrams of higher. So if you divide the one by the other, it seems to be flat here in terms of around 70% being on that magical 60 milligram dose. So again, some people are stable on lower doses, but I think if you look at these, most will still be, or more will still be using illicit opiates on the lower doses than comparing to the ones on the optimal or higher doses. Out of our active prescriptions, about 66% were on 60 milligrams or higher. Okay, we can't do that yet for Suboxone and Cadian because we don't, on our duplicate prescription forms, we don't have the daily dose in one spot. So it becomes impossible to figure out what their daily dose is. The OUD form, by using that, we now have a daily dose spot for Suboxone and Cadian, and we'll be able to track this. Okay. These are all the Suboxone prescriptions created using the OUD form. So now I have the daily dose data that we can separate. So this is a histogram with the different doses along the bottom. And you can see that about half of these, or maybe a bit over half, are at non-optimal doses. And then you can see the Cadian dosing. So out of the OUD form, what's been created for Cadian. And there's no agreement on what optimal dose is for Cadian. I think a commonly accepted conversion right now is a 4-to-1 between methadone and Cadian, though. So if you look at 800 of Cadian, you might think of that as 200 of methadone. Okay, so I didn't show you anything on measuring. I didn't show you any measurement and retention data yet. That's because we really need to start working on entering these two dates here. So in order to measure our retention, we need to know when did they most recently start therapy. That's just entering the date once here. You can ask the patient, when was the most recent time, like how long have you been on methadone this time around? Then put in a date estimate. If you're doing a new start or restart, these dates will automatically reset. Measuring quality of life, we're going to use the PROMIS quality of life scale. It's a simple 10-question quality of life scale. People can do that once or a few times throughout the collaborative, hopefully, and then we can look at the changes in scores over the collaborative time frame. So thinking back to my own patient, what about the guy in his 50s with back pain who ODs on fake oxys, and the guy in his 40s who ODs 1 week into Hep C treatment? I'm hoping that through some of the work of this collaborative, we're aiming for a system that regularly reassesses clients' OUD history and chronic pain and provides necessary education. So maybe if he had a naloxone kit or knew more about the risks of overdose of fentanyl or had access to harm reduction supplies, maybe there would have been some better outcomes. For these other two patients where engagement was a major issue, hopefully we're reducing our system barriers in terms of engagement and maybe providing more outreach where it's indicated. And then hopefully we're making our system more accessible. So for these clients who are working again and doing better on therapy, we want to really facilitate keeping them on therapy and keeping them engaged. So the road ahead, teams continue their PDSA cycles. They continue working on empanelment, and they continue, hopefully, using the OUD form and promoting the form. We have the practice support program doing some QI coaching for us as well, and our core team, so myself, Danielle, and Laura, continue to do this too. The teams are giving us their monthly narrative and quantitative reports. We have monthly webinars, so the first one was on doing measurement. The next one will be on a team from the HIV Collaborative talking about their successes. We have an email listserv, and as I said, our next learning session, December 7th. So hopefully we've covered today our objectives. You now should have a bit of a sense of what our Boost Collaborative aims are, how we're measuring things, some of the changes we're testing. There's a whole change package document with hundreds of possible changes teams can test depending on what they think will fit with their team. You know a bit about some of the teams involved, and hopefully you got a bit of a sense of how the teams are actually doing this improvement work. I mentioned the importance of standardized clinical data entry in order to track our outcomes, and a few things to think about. How might this relate to your own daily practice? How could you apply QI and the model for improvement to care gaps in your own clinical setting? And do you know any topics that might be ready for another collaborative approach? Okay, plans for Boost going forward. So we'll complete this cycle. We've applied for Health Canada funding to expand regionally and with Fraser Health. And we are coordinating with the BC Centre for Substance Use and their work on a community of practice. So if you want to get involved or if you have questions, here's our email, and you can visit our website. We have all our presentations and documents that you can review on our website. All right. Thanks a lot.